placement and TAVI in general. Todd? Let's go back to it.
Thanks, Joe. So I'm going to talk about the sapien valve and what's sort of new and is going on in the evolving landscape of aortic stenosis. Here are my disclosures. So we're seeing improved device iteration and design, really capitalizing on some of the benefits of the balloon expandable platform. And this is really, the benefits of a device that has a low profile height, that has enhanced radial strength, that's very accurate for deployment, and it also achieves its nominal shape most of the time. And I think that's very important. As you look at the spectrum of what's gone on with the sapien valve, starting from the Cribby-Edwards valve to the sapien valve to now the sapien XT, and then the sapien 3, which now is incorporating an outer cloth design, you can see just incremental building on the advantages this type of platform has for the treatment of aortic stenosis. So typically these valves come in two sizes, 23 and 26 millimeters commercially. That allows you to treat people with an aortic annulus of somewhere between 18 and 25 millimeters. 29 millimeter valve is commercially available in Europe. It's part of the Partner 2 trial in the United States. And there's also a development of a smaller valve, particularly for Asian countries where patients tend to have a smaller annulus than they do in the US and Europe. So development of nominal expansion and nominal frame shape is very important, and you want a device that really hits that nominal frame shape. And if you look at the way these valves expand, particularly the balloon expandable valves, you can see they achieve a high degree of circularity with device expansion. And there was a recent paper out of the Vancouver group by Jonathan Leipzig looking at the incidence of eccentricity and expansion in these valves 1 year after deployment. And they showed very low rates of eccentricity and very high rates of achieving nominal circularity. And they conclude that the study demonstrates that the balloon expandable platform had excellent rates of circularity with low rates of eccentricity and maintain that expansion without strut fracture even over a year after deployment. This is important because circularity and achieving that nominal expansion reduces leaflet strength and leaflet stress. And if you see, if you achieve the nominal shape of the platform, the stress on the leaflets, particularly at the attachment points, is less than you have more of an elliptical shape, which then puts stress on not only the coaptation points but also on the attachment points. And so having that circular shape is important, we think. Because if you break it down, durability really comes down to the stress that's placed on the leaflets, how the leaflets meet their coaptation, what type of tissue you're using, and if there's an anti-calcification mitigation. The same things that go into surgical valves. So one of the other things that's been going on, and has been a nice improvement for us, is the downsizing of the sheath, or the insertion sizes. We started off with 22 and 20 French femoral sheaths. Those are now down to 18 French for the NovaFlex system, and then we've got the expandable E-sheaths, which are an incremental improvement, allowing now 16 French E-sheaths to deploy valves. And how these sheaths work is they're a folded sheath, so they go in with a very small outer diameter. You can place them in the smaller vessels, and then as the valve passes through, it expands to allow valve passage, and then goes back to its smaller shape. So it allows us to transfemorally treat much more patients who have a smaller access sites. The balloon deployment system has changed as well. The valves are now not mounted on the balloons externally. They're actually mounted onto the delivery balloon within the patient. So you're able to get a smaller profile height to get the valve into the patient. The valve is then pushed onto the delivery balloon, and with the taper tip, it then tracks very nicely and goes across the annulus, and you're able to deploy the valve. There's been improvement in also the transapical device, going from downsizing from a 26 sheath to a 22 French sheath, and the next generation will be even smaller than that. The delivery system has gotten more ergonomically improved for the operator, and there's a taper tip that allows not only transapical implantation but also direct aortic implantation. So currently, commercially in the U.S., it's about a 50-50 split between TATF. Direct aortic is also a growing population. It's 1% to 2%, but I think we're going to see more direct aortic implants coming up. And just sort of just some brief videos as far as the three separate access sites. Most of the transfemoral implants now are done percutaneously. Access is achieved in the common femoral artery. Pre-closed devices or some other closure devices placed. The transapical is done through a 5th or 6th intercostal space to expose the apex. Then the direct aortic is done through a small upper sternal split that gives direct access to the ascending aorta. All of these approaches use balloon valvuloplasty. There's some question about whether that's even necessary. Olaf Windler has a nice paper out of King's that shows you can actually do these implants very nicely without a BAV, but I think it's still standard for most surgeons and cardiologists to do a BAV before implanting the devices. We use rapid ventricular pacing so that there's no cardiac output before the balloon is expanded, and I think that allows for very nice and accurate deployment. You don't see a lot of jumping of the valves. You don't see a lot of the valves springing open like a spring or a slinky, and if you put the valve in the appropriate spot, it usually stays there. So we've been very happy with the deployment of the valves and how the valves have functioned once we've gotten them in the appropriate location. So it's a volume inflation with rapid ventricular pacing. We just inflate the syringe, and we hold that syringe inflation for 5 or 6 seconds, almost like you would do with a coronary stent, and then deflate the balloon and turn the pacing off. So the total pacing time tends to be around 10 to 15 seconds, and the vast majority of patients tolerate that without any issues at all. So most of you have seen this multiple times, so I'll just, in the interest of time, keep going. So recently, Raj Makkar, who's going to talk this morning, presented the 2-year results from the inoperable cohort of Partner B. This was the first Partner 1 trial, and the 2-year outcomes in those patients who are randomized to medical therapy or transcatheter therapy. And as you see, there maintains a strong survival advantage for transcatheter therapy as compared to optimal medical therapy, including balloon valvuloplasty, even out to 2 years. And in fact, that survival advantage is starting to diverge even more with a delta of almost 25% now. So it's a very nice confirmation of what we know, that by treating aortic stenosis, you're going to get a much better survival advantage versus medical therapy. Sushil Kadali presented at the ACC the 2-year outcomes from the Cohort A group of patients. These are those who are randomized against conventional aortic valve replacement. And again, at 2 years for this trial, you see no difference between transcatheter therapy and aortic valve replacement, conventional aortic valve replacement in the high-risk patient population. So that's also good to see as far as overall survival. If you look at strokes, there was some concern there was a little bit increased rate of stroke early on with the transcatheter therapy. That divergency has not been shown with long-term follow-up. It's been very consistent, and really no significant differences out to 2 years. Perivalvular leak has been something that we've focused on. We've known that because you don't debride the annulus, you don't take the native valves out, you can get perivalvular leak. And trying to define these leaks has been an area of focus, particularly for Cam Douglas and others who are working in this area, and just coming up with a consistent set of definitions, mild, moderate, or severe, and how do you define that in terms of circumference of leak. So mild would be less than 10%, moderate would be 10 to 20%, and over 20% of the circumference would be considered severe. This is important because there's data to show that if patients have perivalvular leak, their overall survival is impacted. And this is from Sushil's presentation once again, showing that if you have anything other than none or trace, you have a worse survival advantage at 1 year or 2 years than you do if you have no perivalvular leak. Honing in on this a little bit more, even if you have mild leak, your survival advantage is impaired compared to those with none or trace perivalvular leak. So doing things to decrease perivalvular leak is important, and trying to make the valves as efficient as possible, I think, is going to be an intense area of focus. A recent paper published by the Vancouver group looking at 5-year data, John and those guys had early experiences, so they're publishing 5-year data, again shows that perivalvular leak is associated with worse long-term survival, even out to 5 years, in addition to the presence or absence of COPD. So even more evidence to the fact that perivalvular leak is going to have an effect on some of these patients. The Italian registry, again, also showed that perivalvular leak was an independent predictor of mortality. If you had 2+ or greater leak, that was a high predictor of those patients who are not going to have good long-term survival. So how do we approach this? How do we manage this? Early on, we sized valves based on single-plane imaging with transesophageal echo. We subsequently learned that multiplane imaging and multiplane sizing is a much better way to go, and this is through the efforts of Raj Makkar here in Los Angeles and the Vancouver group and others who are using multiplane detectors to identify the sizing of the valve more accurately so you can pick the appropriate valve size. It also helps you identify coronary height and other things that are important when you're trying to place these prostheses so that you don't create coronary obstruction and other complications. But valve sizing has progressed predominantly from taking a diameter or drawing a line on the LV outflow tract on the annulus under a long axis by TE to doing area measurements, and that's much more accurate in terms of picking valve sizes. And so there's a lot of emphasis on more appropriate sizing to decrease paravalvular relief. Implants of permanent pacemakers are also interesting. This is from Sushil's paper, and you can see no significant differences between conventional surgery in terms of new permanent pacemaker implantation, not only at 1 year, at 2 years. It's an area of increasing focus because if you look at the incidence of permanent pacemaker implantation after TAVR, it remains relatively low for the low-profile balloon expandable valves, somewhat higher for some of the more self-expanding type valves, not only in terms of permanent pacemaker implantation as seen in this large review, but also the incidence of left bundle branch block after TAVR. It's important because there's now information coming out, some studies that show new conduction abnormalities may have a mortality effect on it. So those patients without new bundle branch blocks seem to have a better survival, almost like you would see with paravalvular leak, than those who do have new bundle branch blocks. And in fact, there's also a paper here looking at the incidence of not only bundle branch blocks, but permanent pacemaker implantation and recovery of left ventricular function. And it shows that, if you have a new bundle branch block or you require a pacemaker, you may not get the benefit of relief of aortic stenosis by improvement of your ejection fraction. So eliminating and reducing the need for pacemakers and conduction pumps is going to be important. Durability of these valves has been good. This is a 3-year study also out of the Vancouver group showing decrease in mean gradient to be prolonged, increased effective orifice area to be prolonged. So the hemodynamic effects at 3 years and beyond has been appropriate in what we've expected. So finally, to conclude, the ongoing Partners 2 trial, which is looking at transcatheter therapy in moderate risk patients. Partner 1 was in high risk patients, those who had an STS predicted risk mortality of 8 to 10% or higher. This is now greater than 4%, so it's a healthier group of population. There was a 2-arm trial looking at inoperable patients and comparing the SAPIEN valve to the SAPIEN XT valve. The SAPIEN XT valve is a cobalt chromium valve, a stronger valve, better radial strength, and that trial has completed enrollment, and we're probably halfway at least through enrollment in Partner 2A, which is a randomized trial, again, comparing SAPIEN XT versus conventional surgery. This compares TA and TF against conventional surgery. There's also nested registries in terms of valve-in-valve, 29 valves, direct aortic valves, and so this will give us additional information and show us how we where we put the guardrails for this type of technology in terms of patient profile and characteristics and risk of surgery. So to conclude, I think, particularly for this platform, design continues to improve. The increased radial strength for consistent circularity is going to probably and hopefully translate it'll increase in improved durability of these devices, lower profile sheaths for safer access, upgraded delivery systems for improved accuracy of deployment, and additional valve sizes so we can treat a larger population of patients. Ongoing data out to 5 years continues to show good results in terms of hemodynamics, and there's additional data showing that some of the unique complications that we see with this in terms of paravalvular leak, bundle branch block, and pacemakers continue to warrant our observation and investigation. Thank you.
Well, thank you, Todd. That was an outstanding review. Our next speaker is Mike Reardon from Houston, who is one of the leading planners and on the executive committee of the core valve trial and one of the expert surgeons on the core valve. Mike?
Thank you, Joe, and thank you, Greg, for inviting me. Let me get my slides up. So we all know why we treat aortic stenosis. We've all seen this slide a zillion times before. You do great till you get symptoms, and then you die. And you die fairly quickly. And we've looked at the medical literature and looked at what medicines we can use for this. There is no medical treatment for aortic stenosis. So that's led to aortic replacement, aortic valve replacement for symptomatic aortic stenosis being a class 1 indication. So most of us as surgeons always thought, well, all these people were coming to us and we were operating on them until we really started to look at it. And we thought this is the spectrum from the lowest risk to the highest risk. We'd operate on anybody they sent us. But what's really happening out in the community was between 30 and 60% of the people never made it to us for evaluation. They got screened out at the family practice level, they got screened out at the cardiology level, or they just chose not to come. And so what that really led to was a world that was divided into this. We operated on people to a certain risk, and then at some risk there was a cutoff because there was this conception that people were old, they were sick, and they just weren't good candidates, so we didn't do anything for them. So people started looking at that, and Todd just showed you the partner trial. The partner trial had an interesting design of inoperable patients. It's a little bit different than the core valve trial, so I want to talk a little bit about the trial design so as you get involved in this, you understand the differences between the trials and between the devices. In the inoperable partner trial, the cohort B, they were randomized between TAVR and best medical therapy, and there was no non-femoral arm. If they were too sick for surgery, they weren't going to let you do an alternative access. And then the partner A randomized between open surgery and TAVR. This is similar to the core valve trial, except for in our extreme risk arm, when we originally designed it, we went to the FDA, and we designed it like the partner trial. But by the time we were ready to implement the trial, the partner data had come out, and the data was so strong in partner B, the FDA looked at us and said, do you really think it's ethical to take people that are non-operative and randomize them to medical therapy? And we, of course, said no. We knew as surgeons these people died if we didn't treat them. We also said that we think these people can undergo limited operations. So in our extreme risk arm, there is an alternative access of subclavian and direct aortic. In our high-risk group, it's very similar. It's randomization between open surgery and TAVR. We completed extreme risk in January of 2012, and we completed high risk in August of 2012. We'll be presenting data on both of these during 2013, and I finally won't have to follow behind Todd with no randomized data. It's never a good place to be in. Now the data from the partner trial was so strong in both B and A that we now have approval for extreme risk patients and high risk patients. So the people that we weren't operating on and the upper 10% of the current operative risks are now approved for the SAPIEN valve. Now we hope as the data comes out we'll find the same thing for the core valve. We don't know yet. The other big lesson we learned from these trials is there was an upper limit that you just shouldn't go beyond. There was a point where no matter if I could magically make your valve better, you never got better as a patient. And treating these patients were futile. We all know people that implant these know I can always make your aortic stenosis go away. I can't always make you better. And so there's a line beyond which we don't cross. And I think as surgeons and as implanters, it's going to be one of our biggest duties to make sure that we don't treat this futile population. Now there is some data on core valve that's really pretty good. This is the advanced trial that was recently presented. This was over 1,000 patients from 44 centers. These were all experienced implanting centers. These were no rookies. 100% of the patients were monitored. All primary endpoints were adjudicated by an independent clinical events committee. All neurologic events were adjudicated by a neurologist, and there was a core lab. So this is a really good study, and it's not like a lot of the registries that were out there. If you look at the demographics, it's very similar to what we're seeing in our TAVR populations right now. These are older patients. They're over 80 years old. They have a lot of comorbidities with them. If you look at the success of the procedure, it's very high. These procedures now can be done with a success that's in the high 90%. And if you look at some of the really major complications, there were no annular ruptures. It's a little bit different with a self-expanding valve than a balloon expandable valve. A self-expanding valve will really never rupture the annulus unless you post-dilate it. There was a very low rate of valve embolization, a very low rate of conversion, and coronary compromise has been very, very low with the self-expanding core valve. If you look at the effectiveness of this valve, it's very similar to what we saw with the SAPIEN valve. These people come out with mean gradients, often in the single digits, and good valve areas that are persistent. In fact, as somebody that implants aortic valves, I not only was stunned, but it was somewhat disheartening at first to see how well these valves actually did, leaving the native valve in place. And of course, symptomatically they improved. Almost all these patients were functional class 3 and 4 to begin with, and almost all are functional class 1 and 2 by the time they're done. Todd mentioned left bundle branch block. That's something we're looking at, and there is a lot of controversy over that. In the advanced trial, which was, again, heavily adjudicated and prospective, there was no difference in outcome if you had a new left bundle branch or not. And there's some pacemaker studies coming out looking at people that had pacemakers coming into the trial, pacemakers who got a patient during the trial, and people who got no pacemaker, and there's no difference in survival. Aortic regurgitation overall tends to be fairly low. There's only about 6 months to 12% of moderate or worse. Now, there's a lot of controversy over whether mild paravalvular leak makes a survival difference, and it certainly did in Raja's early work, but if you look at the continued access, that's actually gone away in continued access. So it's very low transvalvular. These valves, because these valves also attain their nominal shape very well because they sit superannular, they're not intraannular like the balloon expandable valve. So the oval LVOT is okay in a self-expanding valve because the valve sits above it and it rounds out. So if you take an oval annulus and you put a balloon expandable valve in there, you're forcing that annulus to now conform to that valve. You don't really do that with the self-expanding valves. And if you look at survival based on either none, mild, or moderate and severe paravalvular leak does make a difference with survival. Mild or none does not. Well, that's still a worry for all of us that implant these. If you look at the cardiovascular mortality and the all-cause mortality out to 12 months, it's exceedingly good in this elderly, high-risk patient population. Now, here's some of the 30-day outcomes that I found somewhat interesting. If you look at stroke, overall it was 2.9%. We talk a lot about stroke, but it's really fairly low numbers. And as we move into patients who aren't really extreme patients, that number is going further and further down. The interesting thing here is women had significantly more strokes than men. I really can't explain that. We're doing a deeper dive into that right now. Not surprisingly, women had more major vascular injuries and more major bleeding because they tend to have smaller vessels. The all-cause mortality was 4.5%. The cardiovascular mortality was 3.4%. Major bleeding is now, it's still a real problem, but it's coming down as we get into smaller and smaller delivery devices. As Todd mentioned, the XT sapien has gone to 18. All the core valves have always been 18. In the future, we're actually going to have an integrated sheath delivery system, which is 18 outer diameter all the way in. Surtavia is up and running right now. Surtavia, I need to add the Canadian flag to this because it originally was just European and U.S., and we've added Canada. We have sites in Europe, U.S., and Canada, and we're recruiting. It is similar to the Partner 2A trial. It is an adaptive design trial, so depending on the events we see and how fast we accrue, we're going to probably need between 2,000 and 3,000 patients, probably between 2,200 and 25. When people come in and are found to be a candidate for this, before they're randomized, they'll have a quality of life questionnaire and a neurologic assessment so that it doesn't influence. And then they'll be randomized either to the TAVR arm or the open arm. In the TAVR arm, you can just get TAVR or TAVR and PCI. You can do your PCI first, you can do a second, or you can do them at the same time. It was approved in August of 2012 and is now up and running. So in the future, as you look out as surgeons, where are we going to be? Well, depending on what we find in Partner 2A and Surtavia, we may add another 25% of the people we're operating on, beyond the 10% that we've already added in the commercial sapien population, to the TAVR population. So as a surgeon, it's going to be important you remain involved in this, or you're going to have a hard time continuing your program and moving on to the future. Thank you very much. I think I'll just sit here.